Thinking, Practice, and Ethics in Medicine, number 1586, the 2nd of April 2026, Gerald C. EclaireMD Foundation, category General Medicine. Introduction. While watching the Japanese TV drama Team Medical Dragon, I was deeply impressed by the scenes in which Dr. Ryutaro Asada stands quietly on the rooftop of hospital before performing difficult surgery. In those moments, he is not simply resting. He is mentally reconstructing the patient's anatomy, anticipating complications, and simulating different surgical pathways. His mind and fingers are actively working through human organ structure, surgical risk, and possible outcomes before any physical action takes place. Internal simulation as a common cognitive process. This scene strongly reminded me of my own experience over the past decade while writing more than 1,600 medical research papers. In my mind, I also imagine and analyze many different disease cases every day. Although I am not a certified physician or practicing surgeon, the internal cognitive process feels very similar. Instead of visualizing surgical instruments, hand movements, and anatomical structures, I visualize pathophysiological systems, metabolic pathways, vascular mechanics, and the dynamic interactions among multiple variables and outcome changes. My background in mathematics, physics, engineering, and artificial intelligence has naturally trained me to think in terms of structure and interaction as a system, rather than isolated facts. When I analyze a biomedical problem, I often see a spatial strain-stress relationship evolving over time with different frequencies. I mentally simulate how glucose exposure may gradually damage vascular structure, how blood pressure fluctuations apply repeated mechanical stress on arterial walls, and how multiple risk factors interact multiplicatively rather than independently. My mind considers these complications as interacting through multiplication, not addition alone. These internal simulations occur repeatedly, almost automatically, as part of my daily thinking process. Similarity between surgical preparation and scientific reasoning, similar to how Dr. Asada mentally rehearses surgical steps before entering the operating room. I mentally test different hypotheses before organizing them into equations, models, or complete research papers. Over the past 10 years, after completing approximately 1,600 papers, this type of internal simulation has become a natural and continuous part of my thinking. In this sense, the cognitive process behind scientific research and surgical preparation shares an important similarity. Both rely on internal visualization, pattern recognition, and structural reasoning developed through long-term training and accumulated experience. Of course, television drama emphasizes dramatic intuition, while scientific research requires continuous verification through longitudinal data and quantitative consistency. My work integrates both natural intelligence (NI), in which the human brain provides structural insight and pattern recognition, and artificial intelligence tools (AI), which assist in organizing large datasets and validating numerical relationships. This NI plus AI collaboration approach allows complex biomedical phenomena to be analyzed from both macro and micro perspectives. Engineering thinking applied across disciplines. When I saw Dr. Asada standing on the rooftop at night before forthcoming surgeries, I immediately recognized a familiar cognitive pattern. Although our professional roles are different, the underlying thinking process is very similar, continuously constructing internal models, testing possible outcomes, and seeking structural similarities, while attempting to understand complex medical systems in both hard surgical procedures and soft organ pathophysiology. This similarity reflects a shared reliance on visualization-based reasoning, which is commonly found in engineering, physics, and advanced medical problem-solving. In short, Dr. Asada mentally simulates surgical structure, while I mentally simulate biomedical system interactive dynamics. Both processes aim to reduce uncertainty, anticipate risk, and improve decision quality through structured thinking, simulation thinking in high-technology product development, and business decisions. Upon further reflection, I realized that this mental simulation process did not begin with my medical research. When I was managing high-technology businesses, including the development of early portable personal computers, mechanical CAD systems on workstations, and AI-based semiconductor chip design tools, I repeatedly performed similar simulations in my own mind. During both product development and major business decisions, I mentally explored multiple possible paths before taking action, before finalizing a product design direction. negotiating a major agreement with key customers, or structuring an important business partnership. I would mentally evaluate possible outcomes. I would ask myself, if I approach the customer in this way, what response might occur? If the deal structure changes, how might the long-term outcome evolve? If the product architecture is designed in one way rather than another, how might performance, reliability, and market acceptance change? Through this repeated internal simulation process, I could often anticipate potential risks, unintended consequences, and opportunities before implementation. Semiconductor architecture and neural network analogy. After my stroke in mid-2025, when began self-studying neuroscience in order to understand neuron structure, neural pathways, and neural network function, I again found myself using the same internal visualization method. In my mind, I naturally visualized neurons and neural connections in a manner similar to how I had previously visualized transistor placement and electrical routing inside semiconductor chips. I could see both similarities and differences between the human brain and computer architecture. Transistors resemble neurons in their switching behavior, while electrical interconnect pathways resemble neural pathways. However, the density, adaptability, and dynamic plasticity of biological neural networks are far more complex than even the most advanced semiconductor chip designs. Even so, the underlying structural thinking process remained consistent across both domains, one in modern computer science over the past 60 years, and the other in neuroscience, which emerged as an independent medical discipline around 1980. System-level thinking across multiple fields. Looking back, I now recognize that these experiences are very similar to the way experienced surgeons mentally rehearse complex operations. Surgeons often simulate each procedural step in advance, anticipating anatomical variations, technical challenges, and possible complications. In a similar manner, whenever I encountered a new research idea or disease topic among the past 1,600 medical research papers, I followed the same internal process. I constructed a structural understanding of the system, examined interacting variables, and mentally simulated possible dynamic behaviors before organizing the results into a mathematical or conceptual framework. Therefore, this approach is not limited to one discipline. It reflects a consistent system-level method of thinking, observation, decision-making, and process design. Whether the subject involves psychology, pathophysiology, neuroscience, engineering, mathematics, physics, high-technology product development, or business management, I have approached each problem using the same structural method. The domain may differ, but the underlying cognitive framework remains consistent. Construct an internal system-based model, simulate possible outcomes, evaluate interaction effects, and refine decisions based on structural understanding. Medical ethics as the guiding principle. Medical ethics has always been an important guiding principle in my research work, although I am not a practicing physician with an MD degree. My motivation has consistently been aligned with the core spirit of medicine, reducing suffering, preventing disease progression, and helping patients preserve their quality of life. Over the past 17 years, I have self-studied physiology and pathology, applying mathematics, physics, engineering, and artificial intelligence to investigate chronic metabolic disorders and mortality-related conditions that I have personally experienced, particularly ulcerative disease, chronic kidney disease, neuropathy, stroke, cancer risk, and aging. My objective has never been academic recognition or institutional positioning, but rather to develop practical tools and understandable models for myself that may also help other patients detect risky earlier and make more informed daily decisions. Prevention-oriented system perspective. In many traditional clinical settings, physicians must work within time constraints and institutional structures that emphasize diagnosis and treatment after disease has already progressed. My research focus has instead been directed toward prevention, early warning, and understanding system behavior where irreversible damage occurs. By using structural and quantitative approaches such as the viscoplastic medicine theory (VMT) and the triggering sensitivity index (TSI), I attempt to describe how multiple physiological factors interact and accumulate strain over time. This approach reflects my belief that medical problems should not always be viewed as isolated events, but as the long-term result of interacting variables within a complex biomedical system. Longitudinal data, like a movie, provides far more useful information than occasional laboratory tests, which are like still photos, nonlinear, dynamic, time-dependent, and path-based trajectories offer more meaningful insight for disease diagnosis and treatment planning. Responsibility through self-application of methodology. Another important aspect of my work is that I apply these analytical methods to my own health data. This creates a direct sense of responsibility for the validity and usefulness of my research models. My objective is not to produce theoretical discussion detached from real life, but to develop practical understanding that may contribute to risk reduction and improved long-term outcomes. The intention is consistent with the ethical principle of minimizing harm through better understanding of mechanism. Ethical parallel between surgery and quantitative modeling. When I compare my research thinking process with surgeons' mentally rehearsed procedures before performing complex operations, the similarity is not only methodological but also ethical. Both approaches attempt to reduce uncertainty, anticipate risk, and improve outcomes before irreversible damage occurs. Whether through surgical skill or quantitative biomedical modeling, the underlying purpose remains the same: to serve patients' best interests and to preserve human life through thoughtful and responsible decision-making. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand their health, prevent disease, and live longer, healthier lives. This content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C. This content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C.